A 22-year-old primary gravid woman, 10 weeks of gestation, comes to the emergency department because of 3-day history of persistent vomiting. She is treated with IV hydration, pyridoxine, toxylamine. As the resident physician prepares the patient for discharge, he asks who will be picking her up from the ED. She says that her husband will be arriving soon and asks if the hospital staff can refer.
Oma, you still there?
Yes.
Hello?
So yes. Can you hear me?
Oh,
Okay.
yes, now.
She says that her husband will be arriving soon and asks if the hospital staff can refer to her symptoms as stomach flu. She does not want anyone to mention to her husband that she is pregnant because the pregnancy resulted from an oral contraceptive failure and he is not expecting this. Which of the following is the most appropriate next question to ask this patient? Okay,
Okay. So the answer is.
what's your answer?
Oh, sorry, it's B. Sorry.
Okay,
Answer is B. Oh, wait, what is it?
you haven't highlighted that's why I asked.
Yeah, that's why, sorry. Yeah. The goal is to hopefully make sure she's safe, and if she's at risk for partner abuse, to provide her with resources. On related note, unlike for children and elders, there is no reporting mechanism for partner abuse. I don't
Okay,
think it says it. Yeah. Yeah, I think it's the same thing. Yeah.
okay, next. 5 days after admission to the hospital for management of a ST elevation myocardial infarction, a 59-year-old man has the sudden onset of severe abdominal pain, bilateral lower extremity pain, cyanosis of the lower body, and paresthesia. On the hospital day 1 and the 2, he received vasopressor and the inotropic therapy. On hospital day 2, cardiography showed an extensive anterolateral akinesis of the left ventricle. He has no history of serious illness. His medications are metoprolol, lisinopril, simvastatin, and dalteparin. He appears to be in acute distress. Pulse is 105 per minute. Regular respiration 24 per minute. Blood pressure 80/60. Examination shows lower body cyanosis of the lower body cyanosis to the level of the costal margin. Crackles are heard over the lung fields. Distant harsh sounds, but no murmurs are heard. Abdomen is non-distended and non-tender. Pulse are 1 plus in the upper extremity and absent in the lower extremity. Muscle strength is 3/5 in the lower extremity. Sensation to touch and temperature is decreased over the lower extremity. ECG shows sinus tachycardia. Which of the following is most likely explanation of this patient's clinical findings? Okay, ready?
Oh, no one. It's B. Wait, what was B? Arctic embolism. He's got a cyanosis level from aortic embolism. His propiakinetic left ventricle is a risk factor for thrombus generation, which was subsequently squeezed out and enlarged distally. The other choices will not result in isolated symmetric lower body syndrome. Okay, let me see if this is something different here. Like this one. Middle-aged men with STEMI complicated by extensive anterolateral echinesis who on day 5 hospitalization develops bilateral lower extremity pain, paresthesia, cyanosis, hypotension, weak upper extremity pulses with absent lower extremity pulses, most consistent with aortic embolism. Aortic, it's not aortic dissection, tearing chest pain radiating to the back, asymmetric pulses, risk factors of hypertension, cocaine, and amphetamine. It's not pericardial tamponade, hypotension, elevated JVD, distal heart sounds, and electrical alternance. It's not. Okay. Yeah. Okay.
Okay. A 75-year-old man comes to the clinic because of 2-year history of progressive shortness of breath. He has also had an occasional dry cough for the past 6 months. He has not had chest pain, palpitations, swelling of his legs. He has not had chest pain, palpitations, swelling of his legs. Medical history is unremarkable and the patient takes no medication. He has smoked one pack of cigarettes daily for 57 years. He does not drink alcoholic beverage. Vital signs are temperature 37 degrees Celsius, pulse 92 per minute, respiration 18 per minute, blood pressure 122 by 76. Pulse oximeter on room air shows an oxygen saturation 89%. The patient has mild dyspnea when he speaks. Auscultation of the lung discloses fine and dry crackles in the base of the both lung fields. Cardiac examination shows discloses normal S1 S2, no heart sounds or heart jugular venous pulsation is measured in centimeter above the external angle with the head of the bed elevated at 30 degree. Examination of the extremity show clubbing of the disease. Results of complete blood count, serum chemistry, chest X-ray shows scattered reticular opposite of the lung field. There is no hilar lymphadenopathy. Which of the following is the most appropriate next step? Okay, ready?
Yeah. It's B. Wait, that was B again. High resolution CT scan. This is all to say he has chronic lung disease. That's finding possible of fibrosis on X-ray and history certainly concerning for smoking related lung disease. Um, CT scan will tell us if he has a pattern characteristic of hepatic diagnosis or something potentially more treatable, like I don't know what is NSIP. Um, yeah,
Fibrosis has two patterns, usual interstitial pneumonia. Okay, next. A
Okay.
previously healthy old woman who is a sophomore in college. What does it mean?
In college, second year of college.
Oh, sorry. Is brought to the emergency department by her roommates because of an 8-hour history of weakness and vomiting blood and 2-day history of dizziness. He has no history of similar symptoms. She says she overeats in response to stress of her classes. She induces vomiting after consuming a significant amount of food because she feels too full and out of control. She now vomits almost daily. She feels she is slightly overweight. She is physically active, exercise moderately 2 or 3 times weekly. She does not use laxative or diuretics. She has many friends and enjoys walking, enjoys going out socially. She takes medications. She drinks 3 to 4 beers on weekends and does not use illicit drugs. She appears uncomfortable and is tearful and mildly diabetic. She is 157 centimeters tall, weight is 59 kg, BMI 24 kg, parameters for temperature 37, pulse 115 per minute, regular blood pressure 100 by 68. Examination showed tender parotid bilaterally and poor dentition. Results of the most likely. Isn't it bulimia nervosa
Mhm.
or ready?
Yeah. So it's B. Recurrent vomiting results in hypokalemia, so low potassium, hypochloremic, low chloride, and metabolic alkalosis. You lose acid and keep having to make more. Okay. Make sense?
Yes.
Okay.
A 58-year-old man comes to the clinic for a follow-up examination 3 months after beginning warfarin therapy for DVT. He noted blood in his urine 1 week ago but has not seen any since that time. He has not had pain, fever, or increased urinary frequency. He has not sustained any recent trauma. His prothrombin time and INR have been within the therapeutic range during his previous measurement. He has hypertension, BPH medications are warfarin, hydrochlorothiazide, smoked 1 pack of cigarette daily for 40 years, but quit when he diagnosed with DVT. Temperature is 96.7, pulse is 88, permanent respiration 18, permanent blood pressure 135 by 87. The prostate is moderately enlarged. No nodules are noted. This is moderately enlarged, no nodules are okay. PT is high for the meantime. 19-second high serum, urea nitrogen 18, creatinine 1, PSA normal. The in urine on urine 3 plus blood 1 plus protein RBC 2 numerous to count WBC2 high powerful cast negative nitrate negative leukocytosis negative. In addition to the CT scan of the abdomen, which of the following is the most appropriate next step in the management? Ready?
Yeah. ACCT evaluate for kidneys, but they do a very poor job evaluating for bladder. Direct cystoscopy. Yeah. Direct cystoscopy is needed to clear the lower urinary tract of an underlying bleeding mass. Smokers are at increased risk for bladder cancer. That's okay. Let's see if this one says something different. Not this question. Yeah. Middle age, significant smoking history, presence with hematuria, BPH, and signs of BPH, and last demonstrating gross hematuria with no signs of glomerulonephritis, like no RBC cast, all these things, or infection. Yeah. Okay. Leading to concern of bladder cancer, which will be workup with cystoscopy. Like bladder cancer, cancer and pancreatic will almost always be in smokers in India. Kidney, pancreatic, cigarette smoking, cyclophosphamide, occupational exposure as painters and metal workers. Yes. Okay, what else?
Your
Indication
battery is low.
for cystoscopy. Indications for cystoscopies, gross hematuria with no evidence of glomerular disease or infection, obstructive symptoms with suspicion for stricture of stone, um, recurring UTI, microscopic hematuria in a patient with increased risk of malignancies. INR between 2 and 3 is therapeutic for warfarin. Between 2 and 3. Okay. Next.
Yes. A 32-year-old a 32-year-old woman is brought to the emergency department immediately after being involved in motor vehicle collision. She was unrestrained driver. On arrival, she says she has severe pain in her right groin. On examination, any movement of the right hip produces pain. An X-ray of the pelvis shows a completely displaced fracture of the femoral neck. In addition to IV morphine, which of the following is the most appropriate? Displaced fracture. Okay, ready?
Ready. Is of B. Is operative reduction in internal fixation. Femoral fractures are very serious and are almost always treated with operative reduction in internal fixation. Plus or minus prosthetic femoral head, plus or minus intermedural rod fixation. The idea fracture of the femoral neck puts patients at risk for avascular necrosis of the femur. Femoral shaft uh, fractures that are open, break the skins, are an orthopedic emergency require OR cleaning and closure. Yeah.
Okay. A 57-year-old man comes to the physician 1 week after he had a 45-minute episode of slurred speech and clumsiness of her right hand. The episode occurred during his daily work. The symptoms resolved during the next 24 hours. He has no history of similar symptoms. He has a 20-year history of hypertension and 15-year history of hypercholesterolemia controlled with low cholesterol diet and daily exercise. He takes no medication. He has smoked 1 pack of cigarettes daily for 40 years, drinks 1 to 2 glass of wine nightly with dinner. He is alert and fully oriented. He is he is 5 feet 10 inch tall, weight is 86 kg, BMI 27, temperature normal, pulse 88, respiration 10, blood pressure 170 by 90 millimeter mercury. Examination including neurologic examination show no other abnormalities. Daily enteric quoted aspirin therapy is vegan. Which of the following is the most appropriate next step to decrease the patient risk of cerebral infarction? He is not on antihypertensive.
No, he doesn't take any medication.
Hmm. Okay. Okay, antihypertensive. Okay. Let's see.
Right. Okay, so is D antihypertensive. Hypertension is number one risk factor for stroke. Additionally, while smoking cessation is important, it takes years for the deleterious vascular effect of smoking to normalize. The hypertension therapy is needed right now and has a much higher likelihood of success than stopping someone. Habit of a lifetime. Let's say this is something. The most middle-aged men, significant hypertension, hyperlipidemia, smoking history, 1 week of TIA, most consistent with, oh wait, no, it's not TIA. Transient slow speech and clumsiness of right hand, more consistent with lacuna impact. The most important risk factor, lacuna impact stroke, is poorly controlled hypertension. Remember that the common carotid is one of the first branches of the aorta, so if blood is being ejected with high amounts of force, shearing of carotid, atherosclerosis, and stroke. For atherosclerotic disease, coronary artery disease, peripheral, in a patient with every risk factor under the sun, the most important one, I guess the most important factor would be smoking more than diabetes. Four main types of lacunar infarct: pure motor stroke, pure sensory stroke, ataxic, hemiplegia, and dysarthria clumsy hand syndrome. Okay.
Hmm. The 27-year-old primary gravid woman had 21 weeks of gestation comes to the emergency department because of 2-day history of moderate headache, shortness of breath, nausea, vomiting, muscle aches, malaise. She also has had cough occasionally productive of sputum. Pregnancy had been uncomplicated. She had no history of serious illness. Her only medication is prenatal vitamin. She is immigrated to the US from India 6 months ago. Temperature is 38.3 degrees Celsius, pulse 100 per minute, respiration 18 per minute, blood pressure 100 by 60. On examination, breath sounds are decreased at the right lung base. Breath sounds are decreased at the right lung base. Fundal height is 22. Fundal heart rate is 160 per minute. Chest X-ray showed right-sided interstitial infiltrate. Which of the following is the most likely infectious agent? She has not that high fever, isn't it? Strep.
She's just immigrated. He has
Yes.
productive spot sputum and lobar pneumonia or whatever. Lobar, something lobar. I want to go with mycobacterium because he just immigrated, but it can also be strep pneumo, but that wouldn't work with the immigration. With the immigration. Yeah, I guess I'll go with mycobacterium. Yes,
Migraine tuberculosis, like there may be low grade fever, not like 2 day history of fever, isn't it? There probably a long history of fever for more than 2 to 3 weeks, which is low graded. Is it like viral illness, like flu? Very common.
mm, maybe.
Because if Mycobacterium tuberculosis, it would come with a long history. Okay, let's see.
Okay. Wait, what was that? 48. B. 48 B. Oh, it's influenza A. What is, where am I? Oh. B. They are presumably trying to demonstrate that she has an acute viral type syndrome given the flu like illness with fever, muscle aches, and generalized misery. COVID 19 wasn't an answer to. Okay. Note that checks X ray says interstitial infectors, which is the step code for phrase for a typical infection as opposed to consolidative pneumonia. Interstitial infectors. Okay, let's see the other one. Young primigravid woman 21 who presents with acute shortness of breath, GI symptoms, headaches, muscle aches, fever, checks either with unilateral interstitial infectors, most concerning with influenza infection. Wait, influenza? Influenza, oh, influenza A. I don't know why I was reading hepatitis A. Influenza A infection, the flu, muscle aches and GI symptoms, very common infections with influenza. I should know that. And often can help differentiate it from rhinovirus infection and bacterial pneumonia. Key idea. While strep pneumonia is the most common cause of pneumonia, it will lead to local consolidation on chest air, local consolidation. Okay. So, Pseudomonas, I know it's not that. Influenza pneumonia patients, hemophilus influenza pneumonia patients with splenic dysfunction encapsulated or often smokers. Legionella often smokers accompanying hyponatremia, diarrhea, and neurosymptoms. So it's influenza like orthomyxovirus kind of thing.
Okay, a 7-year-old boy is brought to the physician because of 1 year history of poor performance in school. His parents say that he is bright, has many friends, and seems to want to do well in school. His teachers report that he seems frustrated with his own progress and his inability to meet the expectation of his parents. Speech fluency and articulation and motor skills are appropriate for age. Physical examination shows no abnormality when asked when asked when asked to read during examination. He has significant difficulty sounding out words. He is unfamiliar with visual acuity test and audiometry shows no abnormality. Which of the following is the most likely diagnosis? Okay, ready?
Yes. Is the dyslexia is wait, I
Learning
will see
disorder.
again.
Yeah,
Learning disorder. Dyslexia is one of several different learning disorders. Let me see if it says something else here. A learning disorder child has a problem acquiring and applying skills in reading, writing, or math. such as this child who has problems sounding out, like reading unfamiliar words. Okay, I guess that's it. Important learning disorder. Uh, I don't know what that means. Doesn't equal, I guess, intellectual disability, and many individuals with learning disorder have average or above average intelligence. Expressive language disorder, persistent difficulties in comprehension and reproduction of spoken and written language. So you cannot comprehend or speak. This child has appropriate fluency and comprehension for age. He just struggles with new tasks. Okay, next, next.
Yes, yes. A 23-year-old woman who is active duty enlisted airman in the US Air Force comes to the base clinic because of 4-week history of itchy sensation in her right ear. She has not had ringing in her ears or hearing loss. She works as a fuel specialist at the first attributed her symptom to the earplugs she uses when she is on flight blind. The symptom has not improved despite the patient's hearing. Sorry, the symptoms does not improve despite the patient's wearing headphone instead of the earplugs during the past 2 weeks. He has no history of serious illness, takes no medication, vital signs are within normal limits during the examination. Pulling the right pin firmly to the examine the ear canal produces pain. The right ear canals appears erythematous and edematous. The tympanic membrane cannot be fully visualized of the presence of cerebral examination. The left ear shows no abnormality. Which of the following is the most likely diagnosis? Okay, ready?
Yes. So it is 50C. I will see again.
Okay,
Otitis externa, inflamed, painful, infected external auditory canal is consistent with otitis externa. Earplugs are risk factors, both from microabrasion trauma and from contact dermatitis. Let's see if this one says young woman with chronic earplug use who presents with subacute unilateral ear itchiness with physical, notable for ear pain with manipulation of pinna, and red dermatous ear canal otitis externa. Ear pain with manipulation of pinna is very specific for otitis externa, especially on MBME. Key risk factors for otitis externa are trauma, like earplugs and water exposure. It is often treated with like chloroquinolines airdrop, like ciprofloxacin airdrops. I like this explanation better. These explanations. Okay. Next.
a 34-year-old woman who is on active duty in the US Army comes to the military urgent care clinic because of 4-day history of headache, poor nasal discharge, and left facial pain. She has not had fever or chills. She has chronic bilateral knee pain, which she attributes to multiple parachute jumps while she was assigned to the airborne 7 years ago. The knee pain is exacerbated by long distance running on pavement. Her only medication is occasional ibuprofen for knee pain. The patient has no known medication allergies. Temperature is 37.1 pulse, 60 per minute, respiration 14 per minute, blood pressure 122 by 80 millimeter mercury, cervical lymph node are not palpable. There is tenderness to palpation over the left maxillary sinus. Nasal examination shows inflamed turbinates and purulent discharge. The patient needs to blow her nose twice during the examination. Otoscopy examination disclosure abnormality. Examination of the oropharynx shows scant purulent discharge posteriorly. The remainder of the examination shows no abnormal. Which of the following is most appropriate? Okay,
So it is C, which is, wait, let me see, ibuprofen in the congestion therapy. Most acute sinusitis is viral, not bacterial. Most antibiotic used for sinusitis is futile. Nasal irrigation and decongestant therapy are the hallmark treatment to relieve drainage pathway obstruction and give the body the ability to drain secretion properly. Let's see if this one says something. Ibuprofen and decongestant. A young woman presenting with 4-day history of headache, purulent nasal discharge, and left facial pain without fever was consistent with viral sinusitis that should be managed conservatively with NSAID and decongestant. Most cases of sinusitis are viral in origin, but should be concerned for bacterial rhinosinusitis if at least one of the following three criteria are met: persistent symptoms more than 10 days, febrile illness for 3 days more or more, symptoms improve and then get worse. Bacterial rhinosinusitis, you give amoxicillin and clavulanic acid, clavulanate, amoxicillin and clavulanate. Okay.
next. A 16-year-old boy with Vater syndrome. A 16-year-old boy with Vater syndrome is brought to the physician because of 2 week history of rash, of harsh cough that began with a common cold. He receives no medication. Temperature is 37 degrees Celsius, pulse 70 per minute, respiration 20 per minute, blood pressure 112 by 64. Examination shows harsh vibratory sound in the mid anterior chest with forced expiration. A systolic murmur is heard best at the left lower external lobe. There is mild scoliosis. Spirometry shows FEV1, FVC is 2.54. 78% of the predicted and a slow vital capacity 2.88. 85% predicted a flow volume loop show scooping of the expiratory limb. Which of the following is the most appropriate next step? Which of the following is the most likely cause of the discrepancy of this patient's forced and slow vital capacity measurement?
Whose vital capacity is low vital capacity? So,
Okay.
the answer is D. Wait, what is D? Oh, tracheal collapse. Children with beta often have tracheomalacia, part of the T, okay, which can be associated with TEF, like I think that's tracheoesophageal fistula and esophageal atresia. Tracheomalacia results in dynamic airway obstruction due to airway collapse on expiration. So you want to expire and the trachea closes greater when forced. Let me see if this one has something different. Uh, Adolescent boy with bacteria presenting with subacute cough accompanied by expiratory stride or forced vital capacity is bigger than slow vital capacity and a scoop out flow volume, all of which are associated with tracheal collapse. Okay. Forced vital capacity amount of air that can be forcefully expired is almost always equal to slow vital capacity amount of air expired in passive breath, with one exception being tracheal collapse because forceful expiration leads to obstruction, less air expired. Scooped out flow volume low obstructive lung disease, problem getting air out of the lungs, scooped out. Okay. Bacterial is a constellation of mesodermal anomalies leading to vertebral defects, anal defects, cardiac defects, tracheal and esophageal anomalies like tracheoesophageal fistula, renal defects, and limb defects. Okay, I think that's it. Oh, that's the obstruct. I guess that's the scooped out issues. Obstructive lung disease, scooped out, problem getting air out. Okay, that's it.
Okay. A 44-year-old man comes to the emergency department 6 hours after the onset of increasingly severe substernal chest pain in this morning. He says the pain increases when he lies down and coughs. He has had he has also had 3-day history of chills, muscle aches, fatigue. He has hypertension, GRD, medication, sir hydrochlorothiazide, omeprazole. He has hypertension. Sorry, he does not smoke cigarettes, drink alcohol. Temperature 38, pulse 90, respiration 18 per minute, blood pressure 110 by 70. So there is no jugular venous distension, rash organomegaly. On cardiac examination, scratchy sound is heard over the external border, and there is regular rate rhythm, no murmurs. Can you tell me the diagnosis?
The pericarditis.
Yes. So our next step is echo.
53D. Wait, I did echo. Yeah, echo. Chest pain in the setting of upper respiratory infection and with low-grade ST elevation in multiple leads. Pericarditis. The scratchy sound is pericardial rub. Or echo will assess for pericardial effusion, any size and significance, pericardial thickening, as well as for overall cardiac function. Next. Oh, it's the same question that continues.
Okay. Echocardiography shows small pericardial effusion, no tamponade on examination. An hour later, the patient's symptoms and examinations are unchanged. Vital signs are within normal limit. Which of the following is the most appropriate next step? Is it B?
Want me to check? Oh, I have to remove this one.
You are giving C.
I'm trying to no, I'm trying to delete C, but it's not working
Okay,
on my.
no problem.
Sorry, sorry. Is B. Idiopathic and viral pericarditis treatment is a anti-inflammatory. Data shows colchicine and NSAID are for all pericarditis treatment, not just recurrent or prolonged cases, as was once commonly assumed. Next.
Yes, yes. A chief medical officer and a hospital has received several reports that one of her colleagues, a 64-year-old male surgeon, has not been acting like himself recently. An administrative assistant says that during the past 6 months, the surgeon's dictations have become hard to follow and appear to be missing information. Previously, they were comprehensive, easy to transcribe. The assistant adds that after the surgeon missed 3 meetings in a row during the past 2 months, he asked her to send him a text message 5 minutes before the next meeting to let him know its location. Previously, he was always in attendance and on time for meetings. A senior resident also has noted unusual behavior by the surgeon. The resident says that while on rounds 3 days ago, the surgeon listed incorrect indications for a specific surgical procedure. A scrub nurse reported that the surgeon used unsterile practices 3 times during the two procedures. Today, the chief medical officer meets the surgeon and asks him about the reported incident. The surgeon says nothing is wrong. The people who reported him are angry with him for various reasons and trying to stir up trouble. Which of the following is the most appropriate action of the chief medical? Mm, okay, I think B. Okay, let's see. Maybe you are right.
Is D. It's not safe. You have enough information to. Oh, this doesn't even make sense. Never mind. Let me look ahead. It is instruct the surgeon to take a temporary leave of absence and undergo medical evaluation. Doctors are human beings and often would not like to admit that there is a problem. So, in case the
Is it
hospital leader,
possible to directly, if somebody says that a chief medical officer can directly remove that surgeon, is it true or is
yeah,
it
if,
a rule?
if he's above the surgeon, I think chief medical are above the doctors. I'm not sure how it works, but I think they are.
Okay.
Yeah, if he's somebody that's above you, yeah, they can tell you
But if anybody complains that without verification, he can take the charge.
what do you like. Let me see if I understand what you're saying. What do you saying? Like,
Like if I complain against my surgeon and
uh-huh.
one or two nurse complains, is it enough to say that the surgeon is wrong?
Normally he should do investigation, but there is no an answer choice. Like if there was an answer choice that said investigate what Omar and the
Then
nurses
okay.
are saying, I guess that would be the right answer choice. But they didn't give you that option here. Yeah.
The option B, like determine whether other staffs have noticed anything different about the surgeon's behavior. He made
Yeah,
it
but
sound like
no, because at this point there is,
hmm,
if it was only one person, maybe, but it's like three different people. So
okay.
you have to do something to put the patient at safety because at this point, if it's true, he can hurt the patient or something. Yeah. Doctors are human beings and often do not like whatever. So in this case, the hospital leadership needs to enforce that the surgeon receive a medical evaluation and be medically clear before being allowed to practice, both for the benefit of the surgeon and for the patients. Next.
Yes. A 33-year-old woman is admitted to the hospital because of visual field loss following a 48-hour history of acute eye pain. She also has 3-week history of numbness and feeling of heaviness in both legs. She has no history of serious illness, takes no medications. 6 weeks ago, she returned from hiking expedition in the northeastern USA. She has no recent history of international travel. Vital signs are within normal limits. Muscle strength 5 by 5 in the upper extremity, 3 by 5 in hip flexion, knee extension 4 by 5, knee flexor, ankle dorsiflexion, and patellar and ankle reflexes 3 plus bilateral. There is non-sustained ankle conus bilateral sensation to pinprick is absent throughout the lower extremity. Ophthalmologic examination discloses optic neuritis and reconfirms a visual field loss. Which of the following? Is it optic neuritis like MS?
Hmm. Doesn't, I guess, maybe. No, I don't think so because why would MS have to do with her going on the hike? I guess maybe the hardness.
Sorry, maybe the.
Maybe because it was hot and that triggered her MS, I guess. But I don't, because it
In
doesn't look
in
like.
in, in MS, MRI is the most appropriate diagnosis. Lumbar
Okay.
puncture for oligoclonal band.
Yeah. Sorry, I was trying to find. I was trying to pick electron my whatever. I don't know why. I cannot remove this. Anyway. So you think it's MRI?
Wait, 1 second, 1 second.
Okay.
Mm, there is nonsense in ankle conus. All the jark are exaggerated. Uh, knee flank, ankle. Okay, let's see.
Okay. Ready?
Yes, it's MRI, I think so.
It's E. Wait, what was E again?
MRI.
MRI. She has multiple sclerosis, clinically neurologic lesions, deficits separated in time and space. MRI can show evidence of the myelination in the brain to go along with the optic neuritis. These features are more important than oligoponal bands in the CNS. It's not. Young women neurologic symptoms separated by time and place, presenting with optic neuritis, most consistent MS. While diagnosis of MS can be made by MRI or lumbar puncture, MRI should be preferred over lumbar puncture because it's much less invasive. Painful eye movements in a young woman should always make you concerned for optic neuritis and MS. Other MS-related eye condition is internuclear ophthalmoplegia, going with abducting one of the eyes. Next.
A 68-year-old woman comes to the office because she is concerned about developing Alzheimer's disease. She says she has had increasing difficulty recalling names of people and objects during the past 6 months. She has not had difficulty with her activities. of daily living, finances, and shopping. She takes part-time local community college. She has no history of serious illness, takes no medication. She does not smoke cigarettes. She does not smoke cigarettes. Drinks 1 or 5 hours glass of wine. Her mother developed dementia, Alzheimer's disease in her mid-70s. Physical and neurological examination of the patient showed no abnormality. On cognitive testing, she has delayed recall 3 of 5 words. 3 of 5 words. She is able to perform serial exam. Which of the following is the most appropriate next step in the management? Okay.
So it is E. She has no significant cognitive deficit and is thus still normal enough to not require a dementia workup. In real life, I have plenty of evidence she'll never. Anyway, so it's E.
Next, a 55-year-old a 55-year-old man with major depressive disorder is brought to the emergency department 1.5 hours after he was found dead by his brother in his home, acting strangely. On arrival, he is babbling incoherently and cannot answer questions. There are 2 empty pill bottles in his pockets. One is with paroxetine, other is for duloxetine. He is restless, diaphoretic, and says he has severe headache. Temperature is 101.3 degree Fahrenheit. Pulse is 130 per minute. Blood pressure 145 by 105 millimeter mercury. Pupils are 8 millimeter and reacted to light. Deep tendon reflex are 4 plus and symmetric in all extremities. There is spontaneous myoclonus in the upper extremity. Results of the lab studies include complete blood counts, serum electrolyte concentration, creatinine, phosphokinase activity. Thyroid function tests are within reference ranges. After admitting the patient to the hospital for observation and supportive care, which of the following is the most appropriate next step in the pharmacotherapy? Okay.
So it's D. Serotonin syndrome. The most important next step is to remove the offending serotonin and serotonergic agents. Let me see here. A middle-aged man brought to ED after potentially taking a high dose of SSRI and SNRI. Oh, I thought that was DCA. Never mind. Together and presents with agitation, increased neuromuscular activity like increased deep tendon reflexes and myoclonus, and autonomic hyperactivity like fever, tachycardia, diaphoretic, mediasis, which fits for the 3 A's of serotonin syndrome: agitation, activity, and autonomic hyperactivity. Serotonin syndrome often treated with discontinuing, stopping the medication plus cycloheptadine. Oh, it's not dantrolene, dantrolene is for the other one.
Means
Um,
dantrolene is for malignant hyperthermia.
okay, okay, that's right. So, cycloheptadine, serotonin antagonist. So you stop the medication and then you get cycloheptadine. Important to contrast with neuroleptic malignant syndrome, which is often seen in patients taking antipsychotic medications who present with malignant fever, um, malignant fever, myoglobinuria fever, encephalopathy, vital unstable, like autonomic hyperactivity, enzymes are elevated. I'm guessing it's CK. rigidity, and will be treated with dantrolene. Wait, so dantrolene is for malignant hyperthermia
Thermia,
and
yes.
okay. Main difference between serotonin syndrome and NMS are inciting drug and presence of muscle breakdown in NMS. So both have fevers. Okay.
Next,
Mhm.
a 32-year-old man comes to the a 32-year-old man comes to the office for a follow-up examination 2 months after he was diagnosed with hypertension. He arrives late for the appointment and he has stating that to make sure he had to make sure no one followed him here because some drug dealers are after him. He insists that he be seen in examination room with no windows. He says he's fine, but is reluctant to answer questions and reluctant to answer questions because doctors hold everything against me. He doubts his diagnosis and says doctors and drug companies are in cahoots trying to get my money. He refuses to speak with the office manager about his bill because he thinks she looks at me funny and makes nasty remarks about me behind my back. He says he has no history of psychiatric illness. His medical records indicates that he has made similar statements during the past 7 years concerning doctors and office staff. He always refused to elaborate on his statement. His medications are metoprolol hydrochlorothiazide. He does not drink alcohol or illicit drugs. Vital signs are within normal limit. Physical examination and neurological examination show no abnormality. Results of screening labs are within the reference range. Which of the following is the most appropriate next step in the management? Okay,
Can
sorry.
yes, it is E. I was E again. Never mind.
Yes, determine whether the patient has thoughts of
God,
harming
yes.
others.
It will be seen. It will seem to be psychotic. While people with schizophrenia or delusional disorders are on average no more dangerous than other folks. Safety is paramount. Danger to self or others and all that. Okay, let's see. A young man presenting with signs of psychosis, paranoid delusion, is setting of chronic history of similar complaints with an otherwise normal physical and lab workup for schizophrenia or another psychotic disorder. Although patients will likely benefit from antipsychotic medication, main morbidity, mortality associated with schizophrenia and other psychotic syndromes. Easy voices tell the patient to hurt themselves or hurt others, so this patient should first be screened for suicidal ideation. Next.
Just this. A 40 year a 40-year-old man is admitted to the hospital 12 hours after a 40-year-old man admitted to the hospital 12 hours after the onset of the mild right upper part and upper abdominal pain and a pruritic rash over the face, chest, and back. She also has 2-day history of temperature, fatigue, malaise, headache. She has polycystic kidney disease and underwent renal transplant 2 years ago. Her medications are mycophenolate, tacrolimus, and temperature is 101.3 degree per the pulse is 90 per minute, respiration 18 per minute, blood pressure 130 by 80, pulse oximetry On room air oxygen saturation 96%. A photograph of the rash is shown. It appears over the face, scalp, chest, back. Several vesicles contain clear yellow fluid. The abdomen is soft. There is mild right upper quadrant tenderness, palpation. There is no guarding, and the rebound labs leukocyte count 13,000 AST 60 LT 75. Which of the following is the most appropriate next step in the Mm, is it what is this? Is it reactivation or is it pro, rash face, chest, back, uh,
Mm,
renal transplant? She,
have a transplant.
i-
She's on.
she is on she is what immunosuppressed. So immunosuppressed patient reactivation, isn't it? Acyclovir, I think so. Let's see.
It is a cyclovascular rash in the immune compromised
It doesn't look
autonomic.
like that vesicular rash.
It, it's not vesicular at that point. It's like it has exploded.
Oh,
Immune
sorry.
compromise is a common scenario for varicella reactivation. Varicella zoster involvement can result in severe pain that can be mistaken for an acute problem. Treatment is acyclovir and valcyclovir. Let's say this. Yeah, same thing. Women immunosuppressant in setting of renal transplant who present with fever, diffuse vesicular rash, and right upper quadrant tenderness with mildly elevated LFT. Most concerning for disseminated zoster, which yeah, needs to be treated with IV acyclovir. While most cases of hyperzoster will be confirmed confined to a single dermatom, if a patient with zoster has 20 or more vesicles outside of the primary dermatom, then they qualify as having disseminated zoster. Patients with disseminated zoster need to be on airborne contact precaution and should receive chest X-ray and testing for LFT because it most commonly involves the lung and the liver. So follicular folliculitis, postural fever, or systemic features. You give this because of saline or whatever.
Okay. Okay. A 60, sorry, an 87-year-old woman gravida to para 2 is brought to the gravida to para 2 is brought to the emergency department from a skilled nursing care facility because of profuse vaginal bleeding for 2 days. At the age of 41 years, she underwent Cole's knife cone biopsy. She underwent Cole's knife cone biopsy for cervical dysplasia, annual follow-up, and pap smear until the age of 65 years showed no abnormality. She is in moderate distress. Temperature is 36.1 degrees Celsius. Pulse 84 per minute. Respiration 30 per minute. Blood pressure 140 by 90 millimeter of mercury. Abdominal examination shows mild distension and tenderness. No masses are palpated. Pelvic examination shows a large varicose lesion in the perineum, partially covering the anal verge. Speculum examination shows atropic changes in the vagina and the cervix. Which of the following? Okay. Perineum. Palmer's mobile. Is it vulvar? Okay, let's see. Ready? Yes.
Yes. Is E. Vulvar cancer is rarer than cervical cancer is more rare, but has many of the same risk factors, including HPV. Another risk factor worth knowing is lichen sclerosus, which results in itchy vulvar skin. Let me see if they say something different here. Elderly woman with past cervical dysplasia presents with large bleeding verrucous lesion on perineum. Most concerning with vulvar cancer, cervical cancer, vulvar cancer, vaginal cancer, anal cancer, penile cancer are all typically mediated by HPV, consistent with the verrucous nature of the lesion, with this patient having past history of HPV infection given cervical dysplasia. The lesion is not coming out of the anus, so hemorrhoids, rectal cancer, and rectal polyps are ruled out.
Okay, next.
Mhm.
A 47-year-old woman comes to the office for a routine health maintenance examination. She feels well and has no history of serious illness. She examination showed 2 centimeter non-tender nodule in the right lobe of the thyroid gland. There is no lymphadenopathy. Her serum thyroid, her serum TSH hormone concentration is within the reference range. Which of the following is the most appropriate next step in the management? Non. Okay, let's see.
Okay. 62. So it's E. Wait, what was E? Ultrasound of the thyroid. Ultrasound. Thyroid nodules are best evaluated by ultrasound. While large nodules, like more than 1.5 centimeter, are more likely to be benign, there are plenty of.
Malignant.
Oh, sorry, I'm more likely, more likely to be malignant. There are plenty of very
No
large.
problem. Maybe you are drowsy like me.
There are plenty of, and I was so confident when I said, there are more likely, there are plenty of very large, completely benign nodules that would be inappropriate to biopsy. Let's see, here it says something different. Patients presenting with thyroid nodules should all receive like ultrasound and like the thyroid function test. Hypofunctional cold nodule, normal high TSH, more concerning for thyroid cancer. Indications for fine needle aspiration, thyroid nodule greater than 2 centimeters in diameter, or thyroid nodule greater than 1 centimeter with high risk features. So more than 2 centimeters, a big one, or small with high risk features. Let me see if something else. Microcalcifications, irregular marking, etc. Ultrasound is the best imaging modality in evaluating thyroid nodule. Next.
A 1 hour old male newborn is examined in the hospital nursery. He was born at term to a 22-year-old woman, gravida 1 para 1 HIV infection. The mother took antiretroviral therapy throughout her pregnancy and her HIV viral load was consistently less than 1000 copies per ml. She received IV zidovudine. During labor, the patient's Apgar score were 8 and 9 in 1 and 5 minutes respectively. He is at 15 percentile for length, weight and head circumference. He appears well. Examination shows no abnormality in addition to administration of the hepatitis B vaccine. Which of the following is the most appropriate? Okay,
Okay, so it's E, return as it,
zidovudine.
yes. ACT monotherapy during intrapartum and postpartum period, in addition to maternal therapy throughout pregnancy, is recommended for all neonates of HIV positive moms to reduce transmission. Is very effective, less than 1%. Let's see if this one says something different. Baby born to mom with well controlled HIV just gives it within. Born to mom with poorly controlled HIV, like more than 1,000 copies, if multi-drug antiretroviral therapy. Key ideas. Baby born to mother with HIV should be tested for HIV like 24 hours after birth and should not breastfeed. Next.
A 25-year-old woman comes to the office because she has not had a menstrual period for 6 months. Previously, menses occurs at regular 28-day interval. She has not had blurred or double vision. She has no history of serious illness, takes no medication, temperature is 37, pulse 72, blood pressure 108/60. The pupils are equal and reactive to light. Extraocular muscles are intact. Funduscular examination shows no abnormality. Visual field testing show bitemporal hemianopia, milky tissue are expressed from the nipples. Pelvic examination shows no abnormality. Serum study shows a TSH hormone 2, prolactin 100, urine pregnancy is negative. MRI of the pituitary gland shows 1.2 to 1.5 centimeter compressing the uh, optic chiasm. Which of the following is the most appropriate next step in the management? Is it pituitary adenoma?
Yeah, I think, yeah.
Okay.
No, it says a master's compressing. I guess, yeah.
Pituitary gland mass, pituitary adenoma.
Pituitary gland shows a mass compress. Okay, that's we know that. One moment, and it's 1.2, 1.5. And it's creating symptoms. Mm, do we give the carbeg? What was carbegolin? Was it a
Yeah,
dopamine agonist?
yes, bromocriptine cabergoline. This is the drug for oh yeah, dopamine agonist. Yes.
So do we give the dopamine before the surgery or do we go straight to the surgery? I feel like it depended on the centimeter of the, like how big was the thing. Okay, I guess let's just do the surgery.
I think that it's cabergoline. Let's
Oh,
see.
you think we will? Let's see. 60 what is B is carbego. Yeah, it's carbecolin. Oh, we give the thing before doing the surgery. Prolactinomas pituitary adenoma that secrete prolactin and as a result can cause amenorrhea, infertility, lactation, can be treated with dopamine agonists like cabergoline. This is because dopamine normally inhibits pituitary prolactin production. In many cases, tumors can completely involute with pharmacologic therapy alone. Let's see if this one says something. A young woman presenting with an ovulation by temporal myopia and galactorrhea found to have increased prolactin, normal TSH, a normal thyroid function, and like a pituitary mass, most common consistent with prolactinoma. Asymptomatic microprolactin less than 1 centimeter, not treatment. Macroprolactin more than 1 centimeter or symptomatic, you give dopamine agonist bromocriptine carbonate. Indication for surgical resection, very large tumor, like more than 3 centimeters, or tumor increases in size while using dopamine agonist. Key idea hypothyroidism, increased TRH, stimulation of prolactin release, increase prolactin. So when you see an elevated prolactin, it's important to get thyroid function test to rule out hypothyroidism leading to elevated prolactin. Okay, got it.
Next,
Mhm.
a 2 week old boy is evaluated in the neonatal ICU because of temperature instability and decreased activity, temperature instability, and decreased activity. He was born by cesarean delivery at 30 weeks of gestation. Because of premature rupture of the membrane since the birth, he has been fed breast milk by orogastric tube. He was feeding and growing appropriately until today when his axillary temperature was 36.5 and he has decreased activity. During the past 4 hours, gastric residue has been noted. Gastric residue has been noted in the orogastric tube when it is aspirated prior to the feeding. Temperature is 37 degrees Celsius. Respiration 50 per minute. Blood pressure 70 by 40. The anterior fontanelle is soft. Cardiopulmonary examination shows no abnormality. The abdomen is mildly distended. There is mild tenderness to palpation diffusely. Mild tenderness to palpation diffusely. There are no masses. Bowel sounds are decreased. There is small amount of blood streaked stool in the diaper. Blood streaked stool in the diaper. The remainder of the examination shows no abnormality. Leukocyte count is 18,000, 5,000, and yeah, 18,000, 80% segmented, 5% bands, 10% lymphocytes, monocytes. Platelet count is 1 lakh. Blood culture results pending. Which of the following is most likely to confirm the diagnosis?
Hmm.
30 weeks of gestation. I think X-ray. Okay, let's see.
Okay, so it is E. Wait, let me
X-ray of the
double.
abdomen.
A. X-ray of the abdomen. This constellation of symptoms is in a
Premature.
premature infant by 2 weeks of life is neck, necrotizing enterocolitis. The diagnosis is commonly made with abdominal radiograph, which can demonstrate bowel dilation and pneumatosis. And when more severe, frank pneumoperitoneum. Yeah, pneumoperitoneum. Let me see this here if it says something different. X-ray of the abdomen. Premature infant, 30 weeks, who 2 weeks of age, has developed hypothermia, decreased activity, hypotension, abdominal tenderness, bloody stools, and leukocytosis with a neutrophilic predominance, more concerning for neck. Best diagnostic step is X-ray of the abdomen, which shows pneumatosis intestinalis, to below, air in the bowel wall, portal venous gas, air in the portal vein, and pneumoperitoneum, air under the diaphragm. Necrotizing enterocolitis classically seen in premature babies or baby with congenital heart disease. What is it? Measurement of stool reducing substances, lactose and fructose metabolism. Oh, they were showing here. Uh, two is air in the bowel wall. It's like pneumatosis intestinalis. One is air in the portal vein. I guess that's the liver. And then I don't know what is three. I don't see
3.
three. Three
Here
here,
under
but
the
okay.
pneumoperitoneum. Here under the diaphragm.
Other than the diaphragm. Okay, that's it.
A 13-month-old boy is brought to the emergency. 13-month-old boy is brought to a small rural emergency department near his family's community because of erythematous mass in his perineal area that is hot to touch. He has no history of serious illness and receives no medication. Growth and development are appropriate for age. Vaccinations are up to date. He is at 15% for length and weight. Temperature is 103. Pulse 160 per minute. Respirations are 36 per minute. Examination show fluctuations and exquisite tenderness to palpation of the perianal mass. Oral acetaminophen and the dose of oral cephalexin are administered, and the patients are told their child's case is beyond the capabilities of the hospital. They are referred to the nearest hospital with a pediatric service and a suburban hospital 50 miles away. The suburban hospital is contacted regarding the referral, and the pediatric surgeon accepts transport of the patient. When the patient is brought to the ED of the suburban hospital, a triage nurse obtains his oral temperature 37.7, pulse 126. Nurse notes that the family has no health insurance and states that the case is beyond the capabilities of the hospital. The nurse recommends taking the hospital to the ED of a downtown university hospital 4 miles away. The parents follow these recommendations. The patient undergoes incision and drainage of the abscess at the downtown hospital later that day. Which of the following is the most accurate characterization of the patient's pattern of care? Uh, Incision and drainage cannot be done in the local hospital.
What do you mean? Like, I don't
They
understand.
refer this baby to. Okay, let's see. I think that it is E.
It's E. You cannot turf out emergency care that you are equipped to perform just because a
Like
cannot pay.
emergency, like INC, incision and drainage. This is an emergency thing, isn't it? Like in the US,
Uh,
if
uh-huh.
if somebody has emergency acute chest pain, and if PCI is possible on that hospital, even if he is unable to pay, it it is
Yeah.
usually done, isn't it?
Yes. 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 Mm-hmm.
So they are not talking about this, like they are not pointing on that ground. My
Yes.
question is to you.
Mhm. Yes,
I
they are. They
I
are.
think
That's what they're saying.
I
That's what they're
think
saying.
everything in a complicated way. That's why it is a problem.
No, no, no. That's what they're saying. I think I get what you're saying. Like, if it's an emergency, they should have taken care of the. I get what you're saying. Yes, that's how they're thinking. That's how they're thinking. Let me read the other one. But you're right. Near the suburban hospital violated the MTALA thing. Hospital with pediatric surgeon would definitely have ability to drain a perianal abscess, and it's clear that they transfer the patient due to inability to pay. EMTALA emergency stands for emergency medical treatment and active labor. Emergency department that accept payments from Medicare must provide an appropriate examination care to anyone seeking care regardless of ability to pay, legal status or citizenship status. Yeah.
Okay, but in our country it is opposite. That's why I asked.
Yeah. Yeah. Mm,
Trust is an important issue, but people in our country don't trust the doctors. Okay, maybe it's our problem. Okay, a 25-year-old woman is brought to the emergency department by paramedics because of a seizure that began 45 minutes at home. IV anti-epileptic therapy began en route to the hospital has not stopped his seizure. Her parents report that she initially began crying and then fell to the floor, exhibit asymmetric kicking and thrashing of extremity. 15 years ago, he was diagnosed with seizure disorder. Her seizures had been well controlled with oral anti-epileptic therapy until this morning. Today, while the physician is in the patient's room, the movements of the extremity gradually subside. The patient then sits up, asks the physician what happened. She is fully oriented, vital signs are within normal limit. Examination shows no evidence of tongue wearing incontinence and other abnormalities. Which of the following is most likely to confirm that the patient's diagnosis? Okay, let's see. I think it's E.
Okay, let's see, 67. E. Pseudo seizures are diagnosed in, I guess, emergency department with video EEG. You match the behavior with the EEG to see if there are epileptiform discharges that correspond to episodes. While this is clearly observed for an epileptic seizure, possible movement, insane duration, and no post-ictal period, there are plenty of cases of bizarre seizure patterns that are v- VEG, EEG proven. I guess that's what he meant. Let's see, 67. A young woman with past history of well-controlled epilepsy brought to ED because of episode of concerning pseudo-seizure, no post-ictal period, no tongue biting, no incontinence, occur following negative emotional test. What was the negative emotional test? Best test to, oh, he was crying. Best test to confirm pseudo-seizure is video EEG monitoring because you can look at whether the patient's seizure-like symptoms correlate with EEG changes during a true seizure. Measuring anti-epileptic concentration, neuropsych testing, and CK will likely all be done in the ED, but will not help confirm the diagnosis of seizure as the question is specifically asking. Okay.
Next,
Mhm.
a 32-year-old woman. A 32-year-old woman comes to the emergency department because of one-day history of sharp right-sided chest pain that worsens with coughing and sneezing. 4 days ago, she had a mild sore throat and she had a your laptop is running. Okay.
Thank you. Thank you.
I
Thank
don't
you.
know the minor things. I
Thank
I
you. No, thank you, because yeah, I would just be there like
because sometimes because it happens sometimes that your computer has shut down
yeah,
and
and it
I
shut down
start
by
reading
itself. Yeah,
the
I
questions.
know, I know.
Okay. A 32-year-old woman comes to the emergency department. When you got chance, you buy a new
Definitely.
iMac.
Thank definitely.
Okay. A 32-year-old woman comes to the emergency department because of one day history of Sharp right-sided chest pain that worsens with coughing and sneezing. 4 days ago, she had a mild sore throat and a runny nose, followed by non-productive cough. 1 day later, over-the-counter decongestant and aspirin mildly relieve the symptoms. She has not had shortness of breath, blottish sputum, fever, chills. She has a long-standing history of recurrent aphthous ulcer. Her only medication is an oral contraceptive. Temperature is normal, pulse, normal respiration, normal pulse. Oxygen saturation 97%. Splinting is observed over the right hemithorax with deep breathing on cardiac examination. No abnormalities are heard. The remainder of the examination shows no abnormality. Which of following is the most appropriate next step? Okay, ready?
Yes. Let's see. Oh, wrong one. Is D pleurisy.
Yes,
What is
ibuprofen therapy. Yes, you are right.
okay? Ibuprofen therapy. Pleurisy or potentially costochondritis. Pleurisy secondary associated with upper respiratory infection. Either way, treat with NSAID. Oh, I think it's trying to say pleurisy or costochondritis. Treat with NSAID. Let's see if something else. A young woman with recent viral illness like sore throat runny nose who now presents with pleuritic chest pain, but otherwise normal exam and labs most consistent with viral pleurisy. Pleurisy is basically analogous to post-viral pericarditis, and therefore is also managed with NSAIDs. So, pleuritic chest pain, pneumothorax, pleurisy, pericarditis, pulmonary embolism. Oh, chest pain comes with pneumothorax, pleurisy, pericarditis, pulmonary embolism. Whereas recurrent ulcers, pleurisy may also be pointing to diagnosis of pleuritis in the setting of lupus. Okay, next.
A 30-year-old newly-gravid woman who is a military veteran comes to the office because she has not had a menstrual period for the past year. She has not had nausea, vomiting, or night sweat. Menses previously occurred at regular 28 days of interval. She is sexually active with one male partner and uses condom consistently. 3 weeks ago, she returned from a 1 year deployment in the Middle East, where she worked as an army combat medic. She resumed work as a teacher 2 weeks ago. She appears tearful but otherwise in distress. Temperature 37.1, pulse 88 per minute, respiration 16 per minute, blood pressure 116 by 72. Physical examination, including pelvic examination, shows no abnormality. TSH2, FSH7, LH10, prolactin 10, VHH negative. Which of the following is the most likely cause of this patient's anemia? LH-FSH is normal or low?
I don't know about LH, FSH, premenopause is
Yes,
FSH is
this is
7.
normal.
FSH is normal. LH, I don't know because it says follicular phase is 5 to 3, sorry, 5 to 30. A mid cycle phase is 75 to 150. So are we looking at mid cycle or follicular? I don't know. Prolactin is, I think, is normal. Let me see. Prolactin. Female, yeah, it's normal. I think everything else is normal. Hemostatic constipation, amenorrhea. Definitely not prolactin. No more premature ovarian follicle.
It's
Period.
not prolactinoma because prolactin level is normal, isn't it?
Yeah. This
It is not Turner. It is not PCOS because her menstrual cycle is regular. So now B and D. Premature ovarian failure occurs in the early ages, isn't it?
but then not doesn't have to. No. Hypothalamic hypo.
Hypothalamic hypogonadism. So
If it was hypo,
FSH LH is should be low. Then hypothalamus
yeah, doesn't make sense. Hypothalamic hypogonadism.
FSH LH
Yeah,
is normal.
it's normal. Doesn't make sense. And I guess the only thing is premature ovarian follicle. But that would mean the ovary, no estrogen, and FSH should be high. Maybe 10 is high. I don't know.
It
Maybe
is not high. It is
I don't.
below normal or normal.
Yeah, that's the only thing that
B
makes
B fits well.
hypothalamic. But hypothalamic shouldn't prolactin be low. Wait, let me see prolactin. Did I look wrong? Prolactin. Prolactin is normal. Wait, am I looking in the right place there? Let me see. Yeah, it's normal. So, and TSH, wait, TSH
TSH is normal.
is normal too. Hmm.
For
No, no.
hypothalamic hypogonadism to happen, uh, FSH LH should be low, isn't it? And the rest of the thing we should not consider, isn't it?
No, no, I think, well, FSHLH will be low, definitely.
And
TSH,
TNR, yes, and TSH would be low too. You are talking about
yeah,
this.
yes, it should be low too. I think prolactin should also be low. I think
You
so.
are thinking about the hypothalamus pathway, isn't it?
Yeah,
Okay,
or maybe, I don't know. At this point, I know it's between B and D. I don't know what the hell.
okay. Let's see.
Okay, let's see. 69. 69 is B. So I guess it was the hypothalamic hypogonadism. This person recently had normal cycles, essentially excluding A and C. Okay, we know that. We have no reason to suspect D. Wait, why we have no reason to suspect D?
D because okay. Why?
Suspect D. And the normal prolactin exclusive, yeah, we know E. Hypothalamic hypogonadism can have many causes, among them chronic stress and anxiety. Okay, yeah, makes sense. As seen in this patient with eating disorders. How she had eating disorder? And PTSD. I guess she has PTSD because she's in the army. Let's see the other one. Young woman with previously normal periods who has been anovulatory for past year while deployed in Middle East. Likely a stressful and okay, makes sense. Found to have normal physical exam with low FSH. I guess FSH and LH were low.
Low. Yes.
Doesn't make sense. But okay, most concerning with hypothalamic. Guess the key here was she's in the army, goes to the Middle East, war, all these things, so she's stressed. Hypothalamic hypogonadism often seen in setting of physical stress like gymnast, marathon runner, or emotional stress like trauma, medical resident. Turner, no, we know it's not
It
Turner
happens
syndrome.
only for female.
No, I don't think so. I don't think so. Premature ovarian follicle as with menopause patient will expect an increased FSH level because of lack of negative feedback by estrogen. Most commonly seen in patients with past history of radiation therapy, patient with tobacco use, or individual with family member with fragile X syndrome. Okay, okay. I guess the key here, I guess, was no. But I don't understand FSH in LHR.
In here, in the beginning of this, there is a box. Let's see. Wait.
Premenopause. No, it's not more. Or should it be mid cycle? But even if it was mid cycle. I
Okay,
guess we have to look.
okay, FSH weight. Normal FSH for female is 4 to 30 and mid cycle peak is 10,
Mhm,
10 to
mhm.
90 and postmenopausal 40 to 250. Is it mid cycle?
I guess it's the mid cycle that we're looking at. Yeah. I guess we have to look at the mid cycle.
And for LH, the mid cycle is 75
Yeah. So I guess we have to look at the mid
mid
cycle.
cycle. So that is another new.
Mhm. Yeah.
So every woman should. Okay, we have to look at the mid cycle. Why is that?
I
Because
don't
because female premenopausal, all of them are menopausal. 30 year is a menopausal woman, isn't it? Sorry,
know.
sorry. What am I? Pre premenopausal, postmenopausal, premenopause. Oh, okay, postmenopause.
What
Yes.
is that?
Okay, mid cycle. We will look at the mid cycle always in case of female
I guess unless they say specifically that she's menopause, she has menopause.
menopause. Okay. So if we'll remember the mid cycle, like for FSH 10 to 90, for LH 75 to 150, then it is easy that the postmenopausal would be higher than that. Okay.
Yes, menopause.
And for prolactin less than 25,
Mhm.
so it is low too.
Mm, no, wait. Latin, I thought it was normal.
Mm,
It's normal.
prolactin less than 25. Okay. Less than 25 is normal. Sorry. Yes. Okay, okay, okay. I'm working on the wrong direction. Okay. A 45-year-old woman, a 45-year-old woman comes to the office because she has not had a menstrual period for 1 year. Mens previously occurred at regular 30-day intervals. She feels well and has no history of serious illness, takes no medication. She has smoked one she has smoked one half pack of cigarettes daily for 20 years. She is sexually active with one male partner and uses condom consistently. She is 163 centimeter, 5 feet 4 inch tall, and weight is 63 kg, BMI 24 kg per meter. So vital signs are within normal level. Physical examination including pelvic examination shows no abnormality. Measurement of which of the following serum concentration are most likely to confirm the diagnosis. The distance would be okay.
No, no one. So it's B, menopause. Elevated FSH and no period for over a year. Confirm. Oh, so to confirm menopause, you see no period over a year and elevated FSH. To confirm menopause, let's see again if
She
it
had
says
not had menstrual period for a year with the menopause.
FSH, 45 woman with significant smoking who has not had menses for a year with normal BMI, a normal physical most concerning with slightly premature menopause. These factors for managing menopause include previous history of radiation and tobacco use. Um, doesn't it? Patients with menopause decrease estrogen production by ovary, decrease negative feedback hypothalamus, and pituitary increase FSH. Okay. It's FSH and no period.
Okay. It's 45. A 2-month-old girl is brought to the office by her mother for a routine examination. Beyond screening, electrophoresis shows hemoglobin Fs. The mother says her daughter has not had fever or pallor. Patient is feeding well and gaining weight appropriately. She receives no medication. She appears well. She is at 35% of length and weight. Temperature is 37, pulse 158 per minute, respiration 28. All the immunization examination shows no abnormality. All routine immunizations are administered. In addition to a routine anticipatory guidance about feeding and development, the mother instructed to observe the patient's pallor and fever, to palpate for enlarged spleen. Which of the following is the most appropriate to prevent the complication of this patient? Okay, up to 5 years. Okay, sickle cell. Uh,
Ready?
yes, yes.
Is E. Penicillin prophylaxis is indicated in all children with
But
sickle cell younger than 5 years to prevent severe pneumococcal infection. Let's see. Oral prophylactic penicillin therapy, infants with FS, I don't know what is, result on screening electrophoresis. High risk patient has sickle cell disease should have daily penicillin until 5 years of age. First vaccination against strep pneumo. Sickle cell disease functional aspenia due to repeated vascular insult to spleen, increased risk of encapsulated bacterial infection like the shin, strep pneumo, Haemophilus influenza, and Neisseria. Most infants with sickle screening have with FS screening have sickle cell disease, but currently still have fetal hemoglobin circulating, which is the reason for FS. Oh, fetal and sickle. So, okay. Only time. mm, No, it doesn't make sense. Okay, next.
a 3-week-old boy is brought to the physician by his mother because of one-day history of yellow eyes and skin with white stools. Uh, Pregnancy and delivery were uncomplicated. The patient's temperature is 37.1, pulse 160 per minute, respiration 40 per minute, blood pressure 85 by 50. Examination shows diffuse jaundice and cardiopulmonary examination shows no abnormality. The abdomen is non-tender. The liver edge is palpated 4 centimeter below the costal margin. The spleen is palpated 3 centimeter below the left costal margin. Leukocyte 10,000, bilirubin 16, direct ASTLT 800, 500 ml is 100. Next step. Okay, let's see.
Okay, so it's B, the ultrasound.
Ultrasound.
Jaundice in the newborn, when unconjugated, typically is physiologic, with two common causes: breastfeeding due to insufficient intake of breast milk jaundice. In this case, however, the bilirubin is conjugated or direct, which suggests cholestasis. Ultrasound is needed to evaluate the liver and the biliary system. Let's see. Previously healthy 3-week-old boy presented with jaundice, pale stool, direct hyperbilirubinemia, and elevated AST most concerned with biliary atresia. Gold standard diagnosis test is intraoperative cholangiogram, but the initial diagnostic test should be right upper quadrant ultrasound. Classic presentation of biliary atresia is asymptomatic infant who between like I guess 2 months of life, 1 week to 8 weeks or 2 months, will develop direct hyperbilirubinemia due to impaired flow of bile to the duodenum. Pale stools, no bile making it to the intestine, and dark urine, conjugated bilirubin in water soluble. and excreted in the urine. Treatment is surgery. General test taking when asked to provide best initial diagnostic test of a non-invasive answer. huh? When asked to provide best initial diagnostic test, often a non-invasive answer is the correct answer. Helps rule out EGD and colonoscopy in this case. Okay.
Next,
Mhm.
a 52-year-old woman comes to the physician for a follow-up examination. She received the diagnosis of hypertension 3 weeks ago, and lisinopril therapy was begun at that time. She has constant, non-productive hacking cough for 2 weeks, but has not had any other problems. She has no history of serious illness, takes no medications. She does not smoke. She does not smoke. She drinks 1 or 2 glasses of wine daily. She does aerobic exercise 30 minutes 4 to 5 times weekly. Her blood pressure has decreased 164 by 92 3 weeks ago to 140 to 84 millimeter of mercury today. Lungs are clear to auscultation. Which of the following is the most appropriate next step in the management of the patient's cough? Okay.
Okay, so it's D. Wait, am I right? D
Yes,
is
this
discussing lisinopril. Relentless dry cough is a common reaction to ACE inhibitors therapy. Let me see if this one says something else. Middle-aged woman recently started ACE inhibitor who presents with constant non-productive cough. Likely side effect of ACE inhibitors. Stop the medication. Common causes of subacute chronic cough. ACE inhibitors. Stop the inhibitor. Asthma. Get the PFTs. GERD, PPI, give PPI. COPD, PFTs, and imaging. Also pulmonary function test. Upper airway cough syndrome. Just treat empirically with antihistamine medication. If you suspect one of the above causes of subacute chronic cough, but it doesn't resolve with empiric treatment, then you do chest X-ray. Next.
okay. A 27-year-old primary gravid woman, 41 weeks of gestation, is 41 weeks of gestation, is admitted to the hospital for induction of the labor. She has received cervical ripening agents and is now receiving oxytocin. The cervix is 9 centimeter dilated and 100% effaced. The vertex is 0. The vertex is at 0 station. Fetal monitoring show contraction every 3 minutes and reassuring heart rate. She requires pain medication. Which of the following is most likely to adverse effect of IV opioid in this patient? IV opioid, which of the following? Okay.
Okay. So it's 74. E is maternal, no,
Yes, yes,
neonatal
yes.
respiratory distress. Opioids result in floppy babies who don't breathe well, just like they do in adults. Let me see. Side effects of intrapartum opioids in mom: altered mental status, GI symptoms like constipation. Side effects of intrapartum opioids in babies: drowsy, respiratory depression, bradycardia, trouble breastfeeding early on. In adults, opiate leads to pinpoint focus, respiratory depression, altered mental status, constipation. Okay, next.
7-year-old girl is brought to the clinic by his father, by her father because of behavioral problems at school since she started second grade 6 months ago. Her teacher is concerned because she cannot sit still or complete tasks and is not learning at the same pace as her classmate. Psychoeducational testing shows normal intelligence. The patient says his daughter's behavior problems have been worsened since last year. She snores at night and wets the bed several nights weekly. She has no history of serious illness, receives no medication. She has been 25 percentile for height and weight for the past 3 years. Pulse is 105 per minute. Regular respiration is 22 per minute. Blood pressure is 105 by 65. Tonsillar 3 plus. Cardiopulmonary examination and abdominal examination shows no abnormality. On neurological examination, cranial nerves are intact. Deep tendon reflex are 2 plus in all extremity. Finger nose testing shows no abnormality. Romberg sign is absent. Is um, most appropriate. What makes you think that it is polysomnography?
Um, he started acting up like 6 months ago. Bed wetting the bed, snores at night.
Okay, snores. Okay, polysomnography. Okay.
The obstructive sleep apnea can result in ADHD-like symptoms, irritability, and poor growth. The snoring is a tip off, and tonsil adenoid enlargement is the main cause of intermittent airway obstruction during sleeping children. Let's see here. Polysomnography, younger, presenting with behavior problems, snoring at night, and bedwetting with enlarged tonsils on physical concerning for obstructive sleep apnea. Bedwetting can sometimes be caused by obstructive sleep apnea. Polysomnography is gold standard for virtually all sleep conditions like OSA, narcolepsy, REM sleep behavior, blah, blah. No, yeah, that's it.
52-year-old man comes to the emergency department because of increasingly severe pain, swelling of his right foot since he tripped on a rug 2 days ago. He did not fall the next month. The next morning he has redness and dull pain on his feet. He has type 2 diabetes, mellitus, hypertension. Medications are are insulin metoprolol. He is 5 feet 6 inch, weight is 118 kg, BMI 42, temperature normal, pulse 90, respiration 15, blood pressure 145 by 90, pulse oximetry on room air shows oxygen saturation. Pulse oximeter on room air shows an oxygen saturation 98%. The skin over the lower extremities is intact. Dorsal pedis pulses are 1 plus bilateral. Hormone science is negative bilaterally. The right foot and ankle are warm. The right foot and ankle are warm and edematous. There is rubor that decreases with elevation of the extremity. The right midfoot is tender to palpation. Motor examination of the lower extremity shows no abnormality. Siemens Weinstein 5.07. Microfilament testing showed decreased sensation over the both feet. An X-ray of the right foot is shown. Which of the following is the most? It looks like there is a fracture, isn't it?
Oh, really?
I think
Oh,
so.
oh, okay. I thought it was his diabetes, man. Maybe you're right. Okay, maybe surgical reconstruction.
Mm,
Where, right here? Is that what you mean?
yes. Or we should. Immobilize. I think that either E and D and E.
D No, I don't think it's. I don't think it's D. But maybe you're right. I was between B and C. so I was.
No,
So I
no,
was. Wow.
it is not septic.
It's not septic because it's like the.
And duplex ultrasound, if there is a pulse
Yeah,
is low.
and it wouldn't be just on the foot.
Yes.
I guess reconstruction. I don't know why I think it's vancomycin. Okay, fine. I guess reconstruction. Okay, let's see. It is D. Wait, what was D again? Oh,
Immobilize.
immobilization of the right foot in posterior spine. What does he have then? Lis, Lis frank tarsometatarsal
Tarsal dislocation.
dislocation in the setting of Charcot arthropathy, diabetic neuropathic joint. Initial treatment for acute Charcot joint is immobilization to prevent progressive deformity. Okay, so it's like a fracture or not?
Dislocation.
Like dislocation. Okay. Okay.
Dislocation like hip dislocation, like shoulder dislocation. L-
So mobilization of right foot and posterior spleen, middle-aged men with diabetes with signs of peripheral vascular disease, diabetic neuropathy who trip over a rug and now presents with dull pain and redness of the foot and ankle, with foot X-ray consistent with Charcot joint foot. I'll see the image below. Charcot joint foot is a condition primarily seen in diabetic patients with neuropathy, in which there is a vicious cycle in which patient injures the foot, they don't feel the injury, they continue to use it normally, increase the foot injury and inflammation, still don't feel it, they continue to injure it, inflammation of the foot. Medical treatment of charcoal foot joint aim at offloading the foot and preventing future fractures, which can be done with, in this case, with splinting. A patient with polycontrol diabetes will likely try conservative therapy, surgery of the foot because of they are at risk. No. In a patient with polycontrol diabetes, will likely try conservative therapy first. Surgery of the foot because they are at high risk for bone wound healing and post-op infections that could result in foot amputation. Negative hormone sign rules out PE, at least on MBMA, not in real life. Measurement of serum uric acid. Okay, I don't need that one. Let's see. Charcot arthropathy is right here. Lateral X-ray deformation, foot deformity showing dislocation of the tarsal metatarsal. I'm guessing it's something like this part right here, with break in the talus first metatarsal dash line. I guess it's this one, and reduced calcaneal inclination, solid line. It's right here. Okay, so that was the tarsal metatarsal joint break. It says right here, I guess. Okay. Mm,
Okay, next. A 7-8-year-old boy is brought to the emergency department by ambulance 45 minutes after he was struck by a car. He was struck by a car while riding his bicycle. He did not lose consciousness. He did not lose consciousness, but has multiple rib fracture with depression of the left anterior chest wall. His parents have been notified and are on their way to the hospital. On the patient's arrival to the ED, his temperature is 37.2, pulse 150 per minute, respiration 36 per minute, blood pressure 65 by 30 millimeter of mercury. The abdomen is distended with exquisite tenderness to palpation. A rapid IV infusion of 0.9% saline is begun. CT scans are quickly observed and show a disrupted spleen and abdominal cavity filled with free fluid. The patients arrive at the hospital and are informed that their son needs to emergency laparatomy. The parents provide consent to proceed the operation but refuse to consent to transfusion of the blood products and regardless of peoples because of their religious belief. As in saline infusion, blood pressure, patient as the patient transferred to the OT, pulse is blood pressure 50, hemoglobin 3.8, the surgeon agrees with the anesthesiologist the patient will die without transfusion of blood. Which of the following? Okay, okay. C.
Proceed with the wait. C. Proceed with the yeah transfusion. Parents don't get to withhold life-saving emergency treatment from their children, religion or not. Let's see this one. Parents cannot refuse life-saving treatment from the children regardless of the rationale. If the scenario had been like an 18 or more year old individual who religious belief meant they refuse all blood products, then the correct answer would have been to proceed with the operation while abiding with the patient wishes.
Very pathetic. Okay, 78. A female newborn has the onset of tachypnea 4 hours after the birth. He was delivered. She was delivered at term 24-year-old woman following an uncomplicated pregnancy and delivery outgoes for 9 out of 9 in 5 minutes, respectively. Her parents had refused prenatal screening. The patient's temperature 99 pulse, 150 per minute respiration, 60 per minute blood pressure, 55/35 on cardiac examination is single loud S2. Leverage is palpated 3 cm below the right nostril margin. Capillary fill 6 seconds. Peripheral pulses are difficult to palpate. In all extremity, arterial blood gas analysis pH 7.24, PO2 68, bicarbonate pH low, PCO2 low. Sorry, PCO2 normal, bicarbonate is low. Metabolic acidosis. Statistics show increased pulmonary haziness and vascular markings as bilateral pulmonary edema. The most appropriate next in the management of this patient. Each of the following. Maybe is low. Ready?
One moment. Mm, 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 mm. Mm,
They have given fluid. Do they give fluid?
he's having issues breathing and blah, 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 blah. I guess that was metabolic acidosis. That's what you said.
Yes. pH is low, bicarbonate is low.
And he has a single S2. So should we try to keep the PDA open? Ah, I'm not
Single
sure.
H2 8 is not PDA. PDA is continuous mammary.
No, I know. I'm saying that should we, if she's having the issues because of the heart, should we try to keep? But I don't think it's because of the heart because it
But
says pulmonary.
another problem in the chest tissue there is increased pulmonary haziness and vascular markings, bilateral pulmonary edema. If there is pulmonary edema, should we give fluid? Isn't it fluid will increase the pulmonary edema? Isn't it?
Yeah, it's not pulmonary.
Our main concern is to elevate our BP, isn't it?
Yeah, yeah. So it's not that. It's probably not the saline then. It's not the saline.
Because
Is
there
it
is already edema. So our target is to elevate the
so?
pressure
Is
here.
it low enough for bicarb?
Why? What bolus of
The
bicarb
seven.
do what? Nothing.
Okay. 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 Let's see. Oh, it is C. Wait, what was C again?
Alprostadil, you are right in the right direction.
Yeah, I was like, it's just. because usually when the kid starts with thing, you try to
Yes,
figure out if it's a pulmonary of a car or a cardiac. But it didn't make sense why he had the pulmonary edema. I guess whatever. Okay, 78. Cyanotic newborn with a single S2 suggestive of thrombocytopenia. Okay, so it's a heart issue. Congenital heart defect, VSD combined with a single ventricular outflow tract comprising both the pulmonary and systemic circulation. The pulmonary circulation is thus torrential, resulting in pulmonary edema. Like other congenital heart defects that result in early cyanosis, we try to keep the ductus arteriosus open. That's what I was saying. Patients are ductus dependent for oxygenation and mixing and should receive prostaglandin to maintain the PDA. That's what I was trying to say. Let me see if they explain it better here. Wait, wait, wait. Am I in the right one? What happened? Is it not the female newborn? Where did the question go?
they went to roam around.
Okay, I guess the question doesn't exist in here. So let's just believe his spirit is.
It makes sense. Saline actually does not make sense.
Yeah, the saline for sure didn't, but your dopamine also makes sense
And
because you
yes,
say, yeah,
that's the thing I am
yeah,
thinking that dopamine also makes sense.
yeah. I wanted to know like why it's not dopamine. That's why I was
Then
looking
copy
at it.
and paste to
Let's see if it's gonna let me
they will give you because I am doing so.
copy and paste. I didn't even paste. Oh, there you go. What happened?
Okay, the patients I am
Okay.
reading. It's
Uh-huh.
okay now.
Oh, you want me to? Okay. Where is the? Okay, it doesn't say why not the.
Okay, it
Oh,
says okay. The
okay.
bolus of uh, I intravenous dopamine. Dopamine is a vasopressor and ionotrope that
Mm-hmm.
can be used to treat shock. However, in this specific scenario where the shock is likely due to ductal dependent lesion, the primary issue is the closure of ductus arteriosus. Restoring ductal patency with alprostadil is the most critical and the life-saving intervention. Dopamine may be used as an adjunct after alprostadil and has been initiated if shock persists. You got it? So answer is C. I am
Oh,
sending the explanation.
mm-hmm.
You want me to read the other options too?
No, no, I got it. I mean, I guess read the B, but sodium bicarb, please.
Okay, you can see. Okay, bolus of sodium bicarb. The patient has metabolic acidosis, but this is secondary to port perfusion, lactic acidosis from the cardiac condition. Treating the underlying cause is the priority. Administering bicarbonate can be harmful. Administering bicarbonate can be harmful as it can worsen intracellular acidosis and can lead to hypernatremia. Okay,
Okay.
you I have
Okay.
sent the explanation in the chat box.
Mm-hmm. Mm-hmm. Should be here. Got it. Next.
I don't know. We both copy and paste to the same Gemini, but our
Yeah, we did different things, right? Yeah. Yeah, that's so weird. It's really
look,
weird.
I got the actual explanation like you
Yeah,
want.
my explanation even look like that. Yeah, that's weird. Okay, next.
Okay, next. A 43-year-old, a 43-year-old woman comes to the office for a follow-up examination A week after she was discharged from the hospital, following the overnight admission for an episode of crushing, aching, and chest pain, the pain has located behind the sternum. Pain has located behind the sternum and radiated to the left jaw and left shoulder. She also has shortness of breath, palpitation, nausea. Initial ECG obtained on admission showed ST segment depression in V3 through V6. Nitroglycerin was administered. The chest pain resolved. A follow-up serial ECG disclosed no abnormalities and serum troponin were within the normal ranges. Cardiac catheterization obtained the next morning showed no substantial narrowing of the coronary arteries. At discharge, the patient declined meditation. At discharge, the patient declined medication to prevent recurrence of pain. The patient reports that since discharge, she has had two episodes of chest discomfort lasting for 2 to 4 minutes in location, quality of the pain precipitating her hospitalization. Medical history is otherwise unremarkable. She takes no medication. Vital signs are within normal. Physical examination discloses no abnormality. Which of the following is the most appropriate pharmacotherapy?
I don't know. Oh, I didn't do this.
Diltiazem. Why?
Oh, it's propanolol. I'm between
So,
propanolol and dithiazem. Between propanolol and is it the metal angina or just the unstable angina?
the narrowing of the coronary artery. Prince metal isn't it coronary artery vasospasm?
Where did you say narrowing of the corona?
No
No, is it,
substantial narrowing of the coronary artery.
that's
See,
why because I saw no substantial narrowing,
I
so I
think
was
that
like,
no therapy. Okay, let's see.
oh, you think
Okay,
not therapy?
you may be right. You are right.
Oh, okay. Wait, what am I? 79. Oh, vasospastic, yeah, because
Yes.
angina, formerly known as metal angina, rest angina, chest pain, rest or chest pain, rapidly relieved by nitrates in a patient without coronary disease, commonly treated with calcium channel blockers. An alternative possibility that will also yield the correct answer is esophageal spasm. No, I did not think about it. But there is no workup to support that etiology, save the presence of non whatever. Let's see if it says something different here. Wait, what is happening? Am I missing something?
Maybe no
Uh,
explanation is present.
oh, right here.
Yes. Okay.
Right here. Young woman who was recently hospitalized for crushing chest pain resolving with nitroglycerin, with ST depression and clean cardiac catheterization, who continues to have short unprovoked episode of chest pain, most commonly presmetal angina. Presmetal angina should be treated with calcium channel blockers or nitrates. Presmetal angina more common seen in young women who smoke. Oh, she smokes? I don't remember. I didn't remember. Yeah. It doesn't explain why not the no pharmacotherapy. Did she smoke? Did she say somewhere that she's smoking? No, it doesn't say anywhere. Okay, never mind. I would like to know why is it not propanol, why is it not there? Anyway, it's
Then
okay.
copy and paste.
Oh the Lord, it okay.
Okay,
Let's
I'm
do
doing.
oh
So okay, don't copy only the question. Copy answers too.
with the answer to okay, maybe
Yes.
that's okay.
Now you will get the actual. I guess.
Jesus.
Okay.
Why it takes
Which one?
okay.
Propanol, a beta blocker, which is contraindicated, or should
These
be,
are, mhm.
you will get, you have found.
Yeah, beta blockers. These are cornerstone of treatment of angina caused by like atherosclerotic cardiovascular disease because they reduce myocardial oxygen demand. Okay. However, beta blocker can be contraindicated and should be used with caution in vasospastic angina as they can leave alpha adrenergic receptors unopposed, potentially leading to coronary artery spasm. It is not no pharmacotherapy. This is incorrect. The patient is having recurrent symptomatic episodes of chest pain and has documented history of cardiac ischemia. Don't, okay. Pharmacotherapy is clearly indicated. Okay.
Okay.
Last one. Okay, what's the diagnosis? Let's see if I can see it without.
It is easy. What is your diagnosis?
Hmm. Wait. It's not A. Is it AFib? No, AFib is not even an answer. Never mind. It's not A flutter. It's not six sinus. Six sinus. Maybe. I don't know. I don't know.
Look
Oh,
at the
I hate
PR
it.
interval.
Okay, PR. Okay, I will look into, I guess, here. I guess I will here. PR. Uh, I don't know. Wait. It's the same and then it drops. So
Yes.
it will be type 2.
Yes, because there is not progression.
Yeah, there's no progression. Yeah,
So it looks like type 2.
okay, let's
Obese
check.
type. Type 1 is progressive prolongation of the PR
Yeah,
interval.
a type 1 is progressive. No, wait.
Progressive prolongation of the PR interval. PR prolong, then a drop bit. But type 2, it does
No.
not.
So that was type 1. Wait. What's
Type
Mobit's 1?
1. Mobis 1 is progressive prolongation of the PR interval, then a bit is dropped. That is Mobis type 1.
What's
And
first degree then?
first degree is only PR prolonged. PR
Okay.
prolonged and equal. Normal PR interval is 3 to 5 small square, like 400 to, sorry, 40 to 200 millisecond. If it is more than 200 millisecond, it is PR prolonged.
Mm-hmm. Okay, so there is AV concordance, whatever. All QRS have preceding P wave, but we have intermittent drop beats consistent with second degree AV block. The PR interval of the conducted beats is always the same. So we have Mobit's type 2, progressively lengthening PR interval prior to drop QRS is Mobit's 1. Okay, got it.
So we are
Okay,
done.
mm-hmm.